The GCS was initially described in 1974 and is now used worldwide. In 2014, GlasgowComascale.org updated their recommendations for determining GCS in an attempt to improve reproducibility, and these recommendations are reflected in this video. The purpose of this video is to standardize the documentation and approach of the motor GCS as it relates to neuroprognostication post-cardiac arrest. It is meant for those intensivists, ICU fellows, SEND physicians, or others who are involved in neuroprognostication. A longer version of this video detailing the full GCS exam is available at the Glasgow Coma Scale website and is targeted to medical students, residents, and nursing staff. Before proceeding with the examination, check for and remove any restraints. Also, ensure there are no facial fractures. Before performing motor GCS for prognostication, review possible confounding factors. In the ICU, the most common of these factors is sedation, but other confounders could include seizures, electrolyte abnormalities, or sepsis. These and other confounding factors can be found in more detail in the QR code on the infographic for this video. For completing motor GCS, performing a central stimulus is critical to assess the integrity of the higher centers of the brain. For the purpose of neuroprognostication, we recommend at least 2 or more sites be examined. We will review 3 options for central stimulation. Please note that sternal rub is not one of the 3 recommended methods of stimulation, as nerve desensitization occurs quickly. The first stimulus is of the trapezius muscle. Apply pressure to the body of the muscle. Increase the pressure over at least 10 seconds until you are assured of the patient's best response. Supraorbital pressure can serve as the second stimulus to confirm the patient's best response. Ensure no facial fractures, and apply increasing pressure to the notch over 10 seconds. If there is evidence of facial trauma, do not perform this method. The third option for central stimulus is mandibular joint pressure. Although not officially indicated in the performance of GCS, this stimulation method could be used when other stimulation methods are not successful at eliciting a response. Apply increasing pressure for 10 seconds anterior to the tragus of the ear on the mandibular joint. Once the stimulus is applied, the best response will be noted. The 6 options below indicate possible responses. Please note that normal flexion was previously known as withdrawal. For the patient to score a 6 for obey, the patient should perform a 2-step request. The 2-step request aims to eliminate the potential for spontaneous movement or reflex to be observed as obeying. Examples of 2-step requests include making a fist and holding up their thumb, squeezing the eyes shut and opening the eyes, or pointing and flexing at the ankle. If a patient cannot follow commands, apply central stimulus as shown previously. In a localizing response, the patient will bring their hands up towards the central stimulus, passing the clavicle. In a normal flexion, previously known as withdrawal response, the patient would bend their arm at the elbow rapidly, but will not pass the clavicle. To distinguish between normal flexion and abnormal flexion, apply peripheral stimulus to the nail bed. In a normal flexion response, the arm will move quickly away from the body or stimulus. In abnormal flexion, the movement is less purposeful. The patient bends the arm at the elbow in a slow, stereotyped movement. The arm moves across the chest while the forearm rotates with the thumbs clenched. The legs will also extend. In an extension response, the patient extends the arm at the elbow. If there is no movement in the arms or legs, then the rating is none. To enter the neuroprognostication pathway as per CCS guidelines, consider neuroprognostication if motor GCS is less than or equal to 4 at 72 hours post-ROSC or rewarming.